Well, I want to say thank you to the organizers for having me. Just by way of introduction, my research training was in renal developmental biology, and my clinical expertise lies in critical care nephrology in both the neonatal intensive care unit and the pediatric intensive care unit. So I'm very thankful for my collaborators at RTI to help me with the metabolomics analysis, and also my colleague David Ashkenazi at the University of Alabama. Could you see if you could get my slides up here, please? So in terms of my outline, I really wanted to touch a little bit on some embryonic development because it's pertinent to this talk. I also want to discuss a few key points of physiologic adaptation moving from the intrauterine to extrauterine environment, introduce the concept of acute kidney injury, and talk a little bit very briefly about the definitions and some of the confounding variables we have to deal with, particularly in the premature neonates, and then review some of our pilot data. So the goals that we had for this particular project were to determine if postnatal renal maturation results in specific identifiable patterns of urinary metabolites were present across a variety of different gestational ages. We wanted to look at these profiles and see if they were altered in the face of a renal injury in the acute setting. Long term, our focus is to be able to identify urinary profiles that can provide real-time evidence of evolving renal injury. And of course, in order to do that, we have to have a baseline understanding of what the normal developmental profiles look like. Why is this important? Prematurity and low birth weight are a leading cause of our children ending up in the neonatal intensive care unit. And when they end up there, more often than not, they're given nephrotoxic medications. They're susceptible to infections and hemodynamic instability. This can all lead to acute kidney injury. And in many cases, the approach has generally been to withhold nutritional supplementation in these patients. So you could take a bad situation and make it worse. And what we're starting to learn from emerging evidence is that this may result in a reduction in the overall nephron mass, the overall renal mass. And as time goes by, we recruit our able nephrons to actually do more work, and they become damaged over time due to proteinuria and systemic hypertension. This leads to sort of a vicious circle of increased nephron mass and can lead to chronic kidney disease. So it becomes a lifespan issue. We may have people that develop chronic kidney disease as they age. Unlike our colleagues in the adult world and now the pediatric world, we do not have a consensus-driven definition of what acute kidney injury is. An attempt was made several years ago to try and define neonatal acute kidney injury. This has not been universally accepted. We have used creatinine generally as a measure of kidney function, and that is a poor measure. It's a poor biomarker. It's been utilized for about 50 years, but it really doesn't tell us it doesn't give us any idea where the injury happens within the kidney. And by the time the creatinine rises, about 50% of the renal mass has been affected. So it's a very poor biomarker. The genie's out of the bottle. Urine output has been relatively obligatory in neonates because they do not concentrate their urine. They do not have the physiologic ability, certainly in the first week of life, to do so. And so for the purposes of our analysis here, we chose a rise of 0.3 milligrams per deciliter over the baseline serum creatinine and considered that AKI. And the reason we had to do that, and there's variables in the baseline, is because the first week of life, the infant actually reflects maternal serum creatinine. So just to give you an idea from a developmental perspective of where the kidney comes from, you can see from this cartoon, the metanephric mesenchyme is a group of cells that are actually predestined from the intermediate mesoderm to become the kidney proper. And the nephric duct or Wolffian duct gives rise to something called the ureteric bud. It branches into the kidney itself, and through a process of reciprocal induction, it arborizes and starts to form these functional units. And at the end, you're left with a glomerulus, with the zavascular tuft, the proximal tubule, the loop of Henle, the distal tubule, and then the collecting duct. And I'm just going to cue this will just give you an idea of the development. So the first slide is, the first movie here is green fluorescent protein. It's done in time-lapse photography. Let's see if you can cue it up. Sorry for the delay. Can you get it going here? Okay. There we go. All right. So basically, it didn't show it very well, but the stalk is the ureteric bud, and it actually branches out into the actual kidney proper, the metanephric mesenchyme. So the stalk is the most vestigial part of the kidney, and the outer rim or outer cortex, here we go. Look how pretty that is. The outer cortex is the new part of the kidney as it develops. And as a more focal look, the cartoon representation of this represents one of those little bulbs at the end. And in this case, the purple color is the nephric duct, and what branches off of there is the ureteric bud. It grows into the tissue of the metanephric mesenchyme, and you see this glomerular with this little tuft at the end here on the far right, and the proximal tubule right after that, which is where a lot of the activity in the kidney happens, and then the loop of Henle, which is where the concentrating ability happens, the distal convoluted tubule, and then the collecting duct. And this eventually goes on to connect with the bladder proper. So what's really key here is that whether or not the person is inside the uterus or ex utero, kidney development continues till about 36 weeks post-conceptual age. And right now, viability for premature infants has been down to 22 weeks. The majority of renal development occurs in the last trimester. And so we're stretching this out quite a bit. And there's a significant component of time when we have premature infants that they're exposed to a high degree or high possibility of injury in this environment. And that can really impact their actual overall renal mass development. What's really important in terms of premature infants, and term infants for that matter, is that we're functionally born into a state of renal failure. And it takes about a week or so before we start to see progression. And the darkened bars there is a term infant at week 1. We have a glomerular filtration rate of around 20 mils per minute per 1.73 meters squared. The average adult is about 120, so significant change. And if you're a premature infant, you start off at even less functional ability to clear urine creatinine, or serum creatinine. This is reflected in plasma creatinines. These are 2 different studies that have been published based on weight, so 1,000 to 1,500 grams, and also on gestational age. And you can see that there's actually a progressive decrease in serum creatinine measurement over the course of days of life. So one of the bigger issues here is with neonates. If you can imagine, a 2 kilogram neonate has about 160 milliliters of blood. So we track these babies quite often using serum measurements. And it doesn't take very long before you bloodlet these children to the point where they need transfusions. So urine is a much better and a much more bioavailable substance in these infants. So it makes it an important target for us to understand. And because there's not a lot of data in the neonatal patient in terms of alternative biomarkers to creatinine for AKI measurement, we wanted to really understand, at least start to understand, the metabolomic profiling in a normal gestational age group, and then see if we could identify any changes in those infants who had a renal injury. So our experimental design, we used biobank samples from previously frozen specimens, and these had actually been performed for a proteomics biomarker study in the neonatal world. The urine was taken at day 2 of life. There was about 40 samples. We used a nested case control design, 2/3 control, 1/3 AKI for comparison. All subjects in this study were less than 31 weeks gestational age. I've already outlined our AKI definition. We used NMR-based metabolomic analysis with multivariate data analysis, including OPL-SDA. And then our variable importance to projection plots were used for identifying bins that were deemed important for separation of the study groups. So our metabolomics analysis by gestational age, the first stuff I'm going to show you is based on control subjects, and the groups are less than 27 weeks gestation versus 27 to 28 weeks, 27 to 28 weeks versus greater than 28 weeks, and less than 27 weeks versus greater than 28 weeks as a batched sample analysis. Now I'll do the same for acute kidney injury subjects, and then we'll look at the comparison between control and AKI subjects. So for control subjects, you can see our library matched bins, and I just really want to focus on the OPLS data here. Once the data was analyzed, you could see it separated into a fairly nice group of cohorts in terms of the metabolites, and you can see the gestational age in the light green is 27 to 28 weeks, and in the blue is less than 27 weeks. So it separated quite nicely. We found the same thing for the comparison of 27 to 28 weeks versus greater than 28 weeks. And when we looked at this a little closer, you can see a fairly nice progression. There's 9 unique metabolites for the less than 27 weeks to 27 to 28 weeks gestational age comparison, 11 that overlap in this Venn diagram, and then 8 unique ones for the 27 to 28 week versus greater than 28 week comparison. And what's really interesting about this is that in the 70s and 80s, there was a lot of physiologic studies done, and this really correlates nicely. You'll see most of these are amino acids or amino acid derivatives. And the proximal tubule at this time is really starting to learn how to reabsorb amino acids. So this becomes important in our analysis. And this is just the batch data for less than 27 week gestation versus greater than 28 week gestational age for our controls. Once again, a fairly nice separation between the two. And then we looked at our AKI subjects. Once again, less than 27 weeks versus greater than 28 weeks gestational age. Again, a very nice separation once we compress the data. And just to get to the meat of it, what we found is 4 unique metabolites associated with acute kidney injury in this comparison. And it turned out that 2-hydroxybutyrate, ethylene glycol, gluconurate, and N-acetyltyrosine were associated with AKI in our cohort. 2-hydroxybutyrate is interesting. There's actually been a paper published showing its protective effect against paraquat-induced renal injury in a rat model in a preemptive fashion. So there may be a protective component to this. Ethylene glycol is fairly concerning to me because there are issues with carrier fluids, and we know this has happened in the environment in the past in terms of being associated with paracetamol poisoning. And we have no idea what the plastics contain when we manipulate these young infants. N-acetyltyrosine is also promising. Tyrosine metabolism has been reported to be involved with acute kidney injury, and we haven't drilled down into this as of yet, but I think it will turn out to be a fairly important component in our analysis. And Susan told me that most people like to see some sort of spectral analysis, so I had to show this for her. And in the black is our AKI pooled samples, and the red is our control pooled samples, and you can see our N-acetyltyrosine comes out quite nicely in our analysis here. So in summary, renal development involves a series of reciprocal inductive steps. Even small errors or insults can result in significant abnormalities. If we're to understand those injuries and develop new biomarkers or new therapeutic targets for preventing or ameliorating acute kidney injury in the neonate, we have to understand the normative profiling data. Renal development continues, starts at about 6 to 8 weeks conception, continues on until about 36 weeks post-conception, so it's a moving target. We have to understand this. And not all AKI is created equal. So toxic-related AKI may be very different than sepsis-associated AKI, so there may be some unique components to each of these particular insults to the kidneys. Normal renal development processes are important to understand in order to appreciate any AKI-induced changes. So with that, I'm going to say thank you and acknowledge my collaborators here and our funding agencies, including the NIH. I would also like to give a shout out to the PCAN, which is the Pediatric and Infant Center for Acute Nephrology. And there's a group in Europe that is banded together, led by an Italian group, and they have a nephrology, a neonatology group. We have done the same in the US and Canada. There's now 33 centers, and we're banding together to try and improve our understanding of neonatal acute kidney injury. And with that, I'll leave you with this great picture. So, thank you.
Thank you. So, questions?
Fascinating study.
Thanks.
A couple of questions. Do you, we know that acute kidney injury, the recovery from it is much more robust in children and young infants compared to adults. Do you have any data to suggest that the profiles are different in these neonates versus adults with AKI?
So that's a great question, and I believe you're right. We do not have any data on that. So it's been very difficult to get people convinced that there is acute kidney injury in neonates. The problem is neonates are obligatory urine output because they have a dilute urine. So generally in the past, serum creatinine levels have not been measured in these patients if they're peeing. The problem is that the kidney has multiple functions: endocrine, excretory, and also modulating our waste products. And so it's been a bit of a trial convincing many of our colleagues that it's important to actually at least get a few serum creatinine measurements. So we're starting here. I think once we have a good set of data, then we can start to look at how renal recovery happens in this population specifically. So one of the other big challenges we have is we have no good way to count the number of glomeruli in this population in a non-invasive way. There's some MRI data that's emerging, but if we had that, we could understand a lot better the renal mass that happens. Tubules recover, and there's probably a good stem cell population for them. Once the glomerular's gone, it's gone forever. It never comes back. So it's a great question.